This is a personal opinion. My personal opinion is that the best to do is what we are doing is that we do embolization plus surgery in the same operation. Because if you do embolization, you have complications that are happening a few hours after the embolization. You do the embolization in the morning and there is a complication which is a bleed in most of the time in the afternoon. If you do embolization and surgery, a few days later, you combine the complication risk and you increase the complication risk. If you do embolization and in the same general anesthesia, you do the surgery, you have almost no complication of embolization and you really help surgery. So personally, I think that the best to do is to do embolization and surgery in the same operation. As of today, we are participating to plenty randomized study on stroke patients. Stroke patients, it's the best to randomize. Patients are almost the same. They are 67 years old, NIH score of 17 and occlusion of M1. They are all the same. And we have, in Toulouse, we have 350 cases of stroke a year. So when we have a stroke arriving, we wonder in which randomized study we are going to put the patient. The AVM, it's the opposite. You have very young patients, very old patients, superficial AVM, deep AVM, ruptured AVM, unruptured AVM. The angioarchitecture may be extremely different, and you may do nothing, or you may do radiosurgery, surgery, embolization, or a combination of them. So it's almost impossible to embolize, and this is the problem with brain AVM, and the fact that we can't really progress in the data we have and the knowledge we have of what is the better way to manage them. It's because of they are very rare, they are very heterogeneous, and they can be managed with multiple different approaches. I think that for us as operators, the MVM are the more complex procedure we are doing. Today, if you take a team of neurointerventionists, they do a lot of stroke, they do quite a lot of aneurysm, and they do very few AVM. And this is where you really need to have skills and experience, and you use the super fine tricks and ability. So this is something which is very complex to do. It's a problem because to train new generation, the cases are rare. People are mainly doing stroke and aneurysm, and the young generation, it's difficult to train them to do such a complex treatment because it's rare. So I think that the three products are very similar. Onyx and Squid are very, very similar. Fin is a bit different, but finally what you can achieve in terms of obliteration of an AVM is probably very similar, whatever the product you use. So these are three products that enable us to really completely fill an AVM much better than what we were able to achieve with glue before. And when we do preoperative surgery, we really want to completely occlude the AVM, including the vein as well, and then we switch to surgery. When we do radiosurgery, it's the same. People are saying after embolization, you reduce the efficacy of radiosurgery. I think it's not true at all, because we are really filling the AVM itself by using these new products. We need to know how to use glue, and again, it's a very difficult problem regarding the new generation. And because old people like me, we were using glue for years, and we know how to manage it. There is still a place for glue in brain AVM, for deep AVM in very, very small arteries, for cerebellar AVM. So when the catheterization is very, very distal, especially in the cerebellar location, or in very dangerous arteries such as perforators, lenticular striates, thalamoperforators, the best is probably to go very, very distally with a very small catheter, Magic 1.2, and to inject diluted glue. So there is a place for still today for glue. It's rare, and it's difficult to train young people to use it. Yeah, a bright future, I don't know if it's going to be bright, but there is a road, there is a place for embolization. I think that the important point is that it's a multidisciplinary approach. So in Toulouse, we like to do embolisation and surgery. We do the radiosurgery as well. And embolisation has a place in this association of treatment. So you can use it as a standalone technique. You can use it before surgery and, in my opinion, in the same operation. Or you can do it before radiosurgery in deep AVM, in deep ruptured AVM, or when the AVM is too big. So I would not claim that embolization is fantastic, it's better than surgery or radiosurgery, not at all, but it's a complementary treatment. So there is a very important place for embolization today, and I guess for the future for brain AVM management.